Imagine you're holding just a really thick, freshly printed document titled The iMedix Guide to Understanding Colon Cancer.
Oh, wow. Yeah, sounds intense.
Right. You crack the spine, you flip open the cover, and you brace yourself.
Yeah.
You are fully expecting to see, like, cross-sectional diagrams of intestinal polyps or, terrifying charts detailing survival rates.
Yeah, totally. All the dense clinical paragraphs outlining the subtle differences between surgical techniques.
Exactly. You're preparing your brain for pure biology. But instead, you turn to page 1 and you find something entirely different.
Right.
You find this secret internal blueprint revealing exactly how a medical media empire actively manipulates information architecture and, honestly, human psychology just to keep patients from accidentally misusing their medications.
It's wild. Welcome to another deep dive, everyone.
Yeah, if you're joining us today, you are probably familiar with that modern phenomenon of staring at a screen, just utterly paralyzed by the sheer crushing volume of health data out there.
Or the information overload is real.
Yeah, it really is. You're here because you want a shortcut through that noise. And today, we are providing that shortcut by analyzing a uniquely meta-source document.
Which is a profound departure from our standard approach. We are not analyzing a medical condition today. We are actually analyzing the machinery that communicates medical conditions.
Yeah, and to be perfectly clear up front, we are explicitly, purposefully skipping the biological mechanisms of colon cancer today.
Right. No polyps today.
No polyps. We aren't doing a clinical breakdown of the disease because our source material isn't actually a clinical guide. When you peel back the layers of the specific document, you discover the literal internal editorial guidelines for how the iMedix platform constructs its public-facing medical communication.
It's all about the architecture.
Exactly. Our mission today is to deconstruct how platforms like this operate, why patient education requires a massive structural overhaul, and how they tackle the very real crisis of medication misunderstanding. Okay, let's unpack this.
Let's do it.
Because you would think a guide on colon cancer would just be a biology textbook. But looking under the hood of medical media reveals this fascinating mechanical battle against public confusion.
And that battle is fought entirely on the level of infrastructure. The foundational premise of this document is that the way medical information is structured and delivered is just as critical to a patient's survival as, the chemical composition of the medication itself.
That's a huge claim.
It is, but think about it.
Yeah.
You can possess the most accurate, rigorously peer-reviewed, double-blind study data in human history.
Right.
But if the architectural delivery of that data is flawed, the patient is basically left stumbling in the dark. We have to look at how this platform physically organizes its human capital to solve this problem.
Right. Let's look at the very anatomy of this organization. So the source explicitly describes iMedix as an independent medical information platform. And the structural mandate that jumps out immediately is their requirement for a dedicated editorial and medical research team.
Yeah, both together.
Yeah, they aren't just letting doctors write articles on their own, and they aren't just letting journalists summarize medical journals. They're locking them in a room together. But before we get to that collision of disciplines, we need to clarify what independent actually means in this specific context.
Right, purely from a systems engineering standpoint.
Exactly. What does that mean here?
So independent in this structural framework means that the platform's data aggregation is entirely decoupled from the manufacturing and distribution supply chains.
Okay, so they aren't tied to the pharma companies.
Exactly. A pharmaceutical manufacturer's inherent structure is vertical, right? They generate data specifically regarding the molecular compounds they produce themselves. Their information ecosystem is closed.
It's just their own stuff.
Exactly. But by establishing themselves as structurally independent, a platform like iMedix operates horizontally. They are not restricted to one vertical data set. They can aggregate, cross-reference, and synthesize data across thousands of disparate manufacturing sources without prioritizing one pipeline over another. It allows for an uncompromised curation mechanism.
So they are essentially a horizontal aggregator pulling from everywhere without being tethered to the origin point of the drug itself. That makes mechanical sense.
Yeah.
But let's move to that dual team structure. An editorial team forced to work hand in hand with a medical research team. I actually have to play devil's advocate here and push back on this concept.
Okay, go for it.
By explicitly mandating that editors touch raw medical data, isn't iMedix essentially admitting they are altering hard science for the sake of readability or, entertainment.
Hmm.
I mean, if I'm a patient holding a terrifying new diagnosis, I want my doctor unfiltered. I want the raw truth, not something that has been punched up by a scriptwriter so it flows better. Doesn't this introduce a massive point of failure where the actual science gets lost in translation?
If we connect this to the bigger picture of cognitive processing, we actually find that the unfiltered raw truth you're asking for is biologically useless to the average patient.
Biologically useless. That's harsh.
It sounds harsh, but it's true.
Yeah.
We have to introduce a concept here called epistemic translation. In raw medical research, the data is perfectly accurate, right? But it operates within a highly specialized epistemic framework.
Which means,
It's a specific way of knowing and communicating that only other specialists understand. Imagine a researcher sliding a pharmacokinetic profile across the table to a newly diagnosed patient.
I'm going to stop you right there because even that word proves my point. Pharmacokinetic.
Right.
I read a lot, and I have only a vague idea of what that actually entails in a practical sense.
Exactly. Pharmacokinetics is simply the study of how a drug moves through your body, the specific timeline of how you absorb it, how it distributes into your tissues, how your liver or kidneys metabolize it.
And how you excrete it, right?
Right. To a researcher, that single word replaces an entire paragraph of explanation. It's highly efficient for them. But to a patient, it's a brick wall.
Yeah, completely.
The medical research team's job is to ensure that the foundational data regarding that absorption is statistically flawless. But if we leave it there, the patient just drops the paper and walks away. This is exactly where the editorial team steps in to perform that epistemic translation.
Walk me through the actual mechanics of that translation, though. Like, what does the friction in that room actually look like when they have to translate something like pharmacokinetics?
Let's create a hypothetical scenario based entirely on the framework provided in the source document. Imagine the research team brings in a crucial safety parameter for a new medication.
Okay.
The researcher says, this compound has a rapid hepatic clearance rate and is strictly contraindicated with monoamine oxidase inhibitors due to the risk of a hypertensive crisis.
Okay, wow. Let me decipher that. So hepatic clearance means the liver clears it out, and contraindicated means under no circumstances should these two things be in your body at the same time.
Nailed it.
But what is the inhibitor part?
Monoamine oxidase inhibitors, commonly known as MAOIs, are a very old class of antidepressants.
Ah, okay.
And a hypertensive crisis is a lethal spike in blood pressure. So the researcher's statement is mathematically and biologically perfect. But the editor looks at that and recognizes that the cognitive load on the patient is just way too high.
Right, they'd panic or just tune it out.
Exactly. The editor's job is not to dilute the danger. Their job is to construct a narrative framework that a non-expert can actually absorb. The editor pushes back and says, we cannot use the phrase strictly contraindicated with MAOIs. The patient doesn't know what an MAOI is, and they might be taking one under a completely different brand name.
Oh, that's a huge safety risk.
Massive. So the tension resolves when the editor translates it to, your liver processes this drug extremely fast. If you are taking any older depression medications, specifically ones your doctor might have called an MAOI, mixing them with this new drug can cause a sudden fatal spike in your blood pressure. You must check your current pill bottles.
That is brilliant. The researchers provide the raw bricks, the undeniable facts of the chemical interaction, but the editors build the house so the patient can actually walk inside and understand where the danger is.
Exactly. It isn't watering down the science.
No, it is actually making the science survivable.
Yeah.
Because if the patient doesn't understand the warning effectively doesn't exist.
Right.
Which naturally brings us to the next massive shift in their guidelines. Because a translated warning is only indicative if someone actually, consumes it. And the way iMedix demands this information be delivered is, frankly, radical.
Oh, the platform's choice of medium completely subverts traditional pharmacological communication.
Yeah, the guidelines mandate that these medical discussions must sound like a natural, thoughtful, medically literate podcast published directly to the official iMedix YouTube channel.
Which is huge.
It is. They explicitly order their creators to avoid a generic, rigid drug monograph. They want natural back-and-forth dialogue, they require occasional surprise or skepticism, and they outright ban the use of a rigid, repeated structure.
Yeah, it's a total paradigm shift.
To me, it sounds like they're taking the most serious, clinical data imaginable and forcing it into the format of two people having coffee. My instinct is to ask if this trivializes the information, but based on our previous point about translation, I'm guessing there's a deep cognitive strategy here.
There is a profound psychological strategy at play. We need to examine a phenomenon known in healthcare informatics as alert fatigue, coupled with the broader concept of cognitive load theory.
Alert fatigue. Okay, break that down.
Historically, medical information for patients has been entirely authoritative, monologic, and static. It's a dense piece of paper folded into an impossibly small square and stuffed into a pillbox.
Oh, those tiny little pamphlets.
Yes, the font is tiny, the language is dense, and it triggers an immediate psychological rejection. When a patient is bombarded with a static wall of warnings, may cause dizziness, may cause nausea, may cause fatal arrhythmias, their brain reaches a saturation point incredibly quickly.
Right.
This is alert fatigue. They stop processing the severity of individual warnings because the presentation format is just exhausting.
You know, the analogy that immediately jumps to mind is the terms and conditions agreement on a software update.
Oh, that's perfect.
Right. A traditional drug monograph functions exactly like a software licensing agreement. It is completely technically accurate. It fulfills every single legal requirement for risk disclosure. The company has done its job.
And absolutely no one on earth reads it.
Exactly. You just scroll to the very bottom, hit I agree, and move on with your day.
Yeah.
We have been conditioned to completely ignore static walls of text.
That analogy maps perfectly to the problem iMedix is trying to solve. By shifting from a static text monograph to a dynamic conversational podcast format on YouTube, they are bypassing alert fatigue entirely.
By just making it a conversation.
Yeah. Human beings are fundamentally social learners. We evolve to learn through narrative and the observation of dialogue. When a patient hears two voices engaging in a natural back and forth, the brain does not perceive it as a wall of terms and conditions. It perceives it as a developing story.
And the specific requirement for occasional surprise or skepticism is what really fascinates me. Like, why mandate skepticism? If the goal is to deliver facts, shouldn't the hosts just sound entirely confident?
Because unwarranted confidence alienates a nervous patient. The mandated skepticism is actually an architectural tool used to mirror the patient's internal state.
Oh, I see.
When a patient is researching a terrifying potential side effect, they are naturally skeptical and afraid. If the platform just delivers a robotic reassurance, the patient feels dismissed. But in a conversational format, host A can act as the proxy for the patient.
Right.
Host A can say, wait a minute, you are telling me this colon cancer drug can actually cause secondary tumors. How does that make any sense?
And by voicing the exact doubt the listener is silently feeling in their own head, the platform validates the listener's fear.
Oh, exactly.
And then, when host B logically and systematically explains the mechanism behind that risk, the listener is incredibly receptive.
They're primed for the answer.
Yeah, the retention of that safety information must skyrocket because they weren't just lectured to. They witnessed a Socratic dialogue where a problem was presented, challenged, and resolved.
Precisely. It transforms the patient from a passive recipient of data into an active participant in a logical progression. The conversational medium isn't just a gimmick to make the medicine go down easier. It is a highly engineered cognitive pathway designed to ensure the safety parameters actually lodge in the patient's long-term memory.
Wow.
And this accessible gateway is absolutely necessary because of the sheer density of the infrastructure it sits on top of.
Which brings us to the core structural pillars of the iMedix ecosystem. The source text makes a very clear, deliberate distinction here. It states that the platform provides a drug database alongside educational resources, and that both are required to address medication safety and treatment questions.
Right, they are separating the two.
Yeah, they are separating the raw data from the education, but physically pairing them on the platform.
This separation is vital to understanding their methodology. In information architecture, a drug database is a relational system of raw, uninterpreted facts. It's the lists of molecular weights, the chemical nomenclatures, the half-life statistics, the raw incidence rates of adverse events.
Just the number.
Pure architecture. Educational resources, conversely, are the narrative scaffolding built around those facts to provide situational context.
Here's where it's really interesting. Because having a massive comprehensive drug database without the paired educational resources is like having a highly detailed topographical map without a compass.
Oh, that's a great way to put it.
Think about it. If you drop me in the middle of a dense forest and hand me a map that meticulously details every single tree, every subtle elevation change, every river, you've given me a perfect database. The data is flawless.
Yep.
But if you don't give me a compass, if you don't give me the educational resource to teach me how to orient myself, how to find north, and how to relate my physical body to the data on that paper, I'm just going to walk in circles. I have all the facts in the world, but I am entirely incapable of answering the only treatment question that matters. How do I get out of this forest alive?
The danger of providing raw data without a compass in medicine really cannot be overstated. A database alone can actually cause direct harm. Let's trace a hypothetical user journey to illustrate this.
Okay, let's hear it.
A patient is prescribed a new medication and decides to look it up on a raw database. They scroll down to the adverse events section and see a data point: risk of severe hepatotoxicity.
Which means severe chemical-driven liver damage.
Correct. The database has fulfilled its function. It reported a statistically verified fact. However, without context, the patient experiences immediate panic. They might conclude the medication is a poison and abruptly cease taking a life-saving treatment without consulting their physician.
Right.
The database was accurate, but the outcome was disastrous. The educational resource is the mechanism that steps in to prevent this.
Alsa.
The educational layer surrounds that raw data point and adds the necessary denominators and situational variables. It explains, yes, hepatotoxicity is a documented risk. However, this occurred in 0.04% of clinical trial participants, and nearly all of those individuals had pre-existing advanced cirrhosis of the liver and were simultaneously consuming alcohol against medical advice.
It provides the denominator. That is exactly it. A database just gives you the numerator, the bad thing that happens.
Right.
The education gives you the denominator. The vast context of everyone it didn't happen to and the specific variables that triggered it. You cannot navigate a treatment question with just a list of bad outcomes. You need the synthesized context to understand how those outcomes apply to your specific real-world life.
Exactly.
And that exact friction, the gap between the sterile data and the messy reality, is the entire reason this editorial guide was written.
It leads directly to the source text's most urgent directive. The guidelines explicitly highlight the absolute necessity to explain real-world patient misunderstandings. They mandate that the creators discuss practical safety implications and clarify why people often misunderstand medication risks.
Because they know the weak point.
Exactly. The architects of iMedix recognize that the largest vulnerability in any medical treatment plan isn't the chemistry of the drug, it is the behavior of the human taking it.
I want to hypothesize about this for a second, just putting myself in the shoes of someone holding a new prescription. Why do we so consistently misunderstand these risks?
It's a great question.
If the stakes are literally life and death, why is our comprehension so poor? My initial thought is that it's simply an issue of literacy, that the legal jargon is too complex. Or maybe it's just human nature to swing between two extremes. We either read one scary word and completely panic, or we see a massive wall of warnings and just ignore the whole thing out of sheer exhaustion. Is it a language problem or a behavioral problem?
What's fascinating here is that the root cause lies much deeper than language or simple behavior. It is a fundamental flaw in human neurobiology, specifically regarding how we process statistical probability.
Neurobiology, really?
Yeah. Behavioral economists refer to this as denominator neglect, intertwined with the availability heuristic. Human beings did not evolve to intuitively understand abstract statistics like a 1 in 10,000 risk.
We just can't picture that.
Right. Our brains are wired for narrative and immediate localized threats. When a patient is told there is a 1 in 10,000 chance of a catastrophic side effect, they often cannot rationally weigh that against the invisible long-term benefit of the medication.
We just focus on the one.
Exactly. The brain fixates on the numerator.
Yeah.
The dramatic, terrifying outcome is highly available to our imagination. We picture ourselves as the one, which induces panic and leads to medication non-adherence.
And what if it's a common side effect?
Conversely, if the side effect is described as common, occurring in 1 in 10 people, but the effect is mild, like dry mouth, the brain might dismiss the warning entirely because it doesn't sound life-threatening.
Right.
But they're ignoring the fact that severe dry mouth can lead to accelerated dental decay. We are just biologically ill-equipped to process raw risk data accurately.
So when a patient misunderstands a risk, it isn't just a failure to pass a reading comprehension test. The practical safety implications are immediate and physical. A misunderstood warning label results in an accidental double dosing, a dangerous dietary interaction, or a patient abandoning a necessary treatment.
Which happens constantly.
This is why the iMedix guidelines don't just say, tell them the risks. They mandate that the platform must clarify who may be affected and why.
The who and why is the antidote to denominator neglect. By specifying the exact demographic and the biological mechanism of the risk, the platform forces the abstract statistic into a concrete reality.
Give me an example of how that works.
If the platform merely states, may cause orthostatic hypotension, the patient ignores it.
I would.
Right. But if the educational resource explains, if you are over the age of 65 and you stand up too quickly out of bed in the morning, this medication prevents your blood vessels from constricting fast enough, causing a sudden drop in blood pressure that could make you pass out and fracture your hip, that is a profound transformation of the data.
The abstract warning just became a highly specific, visualized scenario. You can actually picture the act of standing up out of bed.
Yes.
You've given the patient a mechanical understanding of the why, which allows them to modify their behavior safely. But how does the editorial team actually execute this on a larger scale? Like, how do they tackle the truly massive, complex safety warnings issued by government agencies?
That takes a specific framework.
Right, which brings us to the final analytical section of the source text. There's strict rules on regulatory context and pedagogical comparison.
The source provides a very clear two-pronged methodology for this execution. First, the guidelines require examining the relevant regulatory or warning context. Second, they mandate explaining how the issue compares with similar drugs or situations. Let's analyze the regulatory context first.
Why does iMedix feel the need to unpack the regulatory context? I mean, if the FDA issues a severe warning, shouldn't a platform just boldly print FDA warning and leave it at that? Why analyze the bureaucracy behind it?
Because a raw regulatory warning, particularly an FDA black box warning, functions as the loudest, most terrifying alarm in the medical ecosystem. But an alarm only tells you that a fire exists. It does not tell you where the fire is located, what combustible material caused it, or the specific method required to extinguish it.
Right.
If a patient simply reads FDA black box warning, risk of gastrointestinal perforation, the sheer terror of that phrase induces a paralytic state. Examining the context means dismantling the alarm to show the patient how the wiring works.
Let's role play this, exactly how the iMedix editors would approach it. Let's take that specific warning, gastrointestinal perforation. As a patient, that sounds like my stomach is going to explode.
It does.
If I just see that in a database, I am throwing the pills in the trash. How does the platform translate that using regulatory context?
The editorial team would dig into the history of the regulation. They would script a conversation where one host explains, the FDA mandated this severe warning because during a 5-year post-market surveillance study, they found an increased incidence of microtears in the intestinal wall. However, this regulatory action was specifically driven by data from a subpopulation of patients who were concurrently taking high-dose NSAIDs like ibuprofen for chronic pain.
Oh, wow.
Right? By explaining the machinery and the historical trigger of the regulation, the warning is demystified. It transforms from an arbitrary, terrifying mandate from a faceless government agency into a highly specific, logical piece of actionable advice. Don't mix this with high doses of ibuprofen.
That is incredibly effective. It shrinks the poster down to a manageable size.
Exactly.
And that leads directly into the second prong of their methodology, comparison. How the issue compares with similar drugs or situations. To me, this is the most visceral tool they have. Let's think about how we process invisible risks, like the physical strain on your body from a new medication. A raw statistic means nothing. But what if we anchor it to a physical sensation the listener already knows?
Like what?
Instead of saying a drug causes a 20% increase in cardiovascular output, which sounds totally abstract, you compare it to a real-world baseline. You say, taking this medication places the same amount of cardiovascular strain on your heart as riding a high G-force roller coaster for 30 seconds, as opposed to the baseline of just driving your car to work.
That is a highly effective pedagogical anchor. You are mapping an invisible statistical medical risk onto a visceral somatic memory the patient already possesses. Everyone knows what the physical pressure of a roller coaster feels like. By utilizing comparison, the platform bypasses the patient's inability to process statistics and taps directly into their experiential memory. If a new psychiatric medication has a specific sedative profile, comparing it to the drowsiness you feel after taking an over-the-counter antihistamine during allergy season provides immediate intuitive mastery over the concept. The patient instantly understands the practical reality of the side effect.
But, this raises a question about the limits of this methodology. If the goal is to provide context and comparison, how much is too much?
This raises an important question, yes.
Because if a patient comes to iMedix to understand medication A, and the platform starts explaining the regulatory history of the FDA, and then compares medication A to medication B, C, and an allergy pill to establish a baseline, don't you eventually cross a threshold where you plunge the patient right back into the overwhelming sea of information overload they came to your platform to escape?
That is the most precarious tightrope the editorial team must walk. The threshold of context is razor thin.
It has to be.
The pedagogy of comparison is exceptionally powerful, but it must be applied with surgical precision. The core objective of the platform is to reduce friction between the patient and the truth. If a comparison requires a lengthy digression to explain the secondary drug being used as the anchor, the tool has failed.
Right, you've just added more noise.
Every single comparison, every piece of historical regulatory background, and every Socratic dialogue must serve a singular, ruthless purpose. Absolute clarity regarding the immediate safety of the listener. If the context obscures the action the patient needs to take, it must be cut.
It's a staggering balancing act. When you look at the sheer amount of invisible labor happening here, it's just mind-blowing. They're aggregating raw, horizontal data, filtering it through medical researchers for accuracy, handing it to editors for epistemic translation, scripting it into a dynamic Socratic conversation, anticipating and neutralizing human cognitive biases, dissecting government regulations, and anchoring everything with somatic comparison.
That's an entire ecosystem.
And they are doing all of this just to make sure a single person understands how to safely swallow a pill. So what does this all mean? When we pull all the way back and look at this meta-document as a whole, the core realization is profound.
It really is.
This guide reveals that modern medical communication has evolved far beyond the simple distribution of facts. It is no longer enough to just tell someone, here's the biological mechanism of colon cancer, or here is the half-life of this compound. Patient education is an active, aggressive, multidisciplinary war against misunderstanding. And platforms like iMedix are fighting that war by building an entirely new architecture of empathy and translation.
It represents a fundamental paradigm shift in healthcare informatics.
Yeah.
We are moving from passive, authoritative data dumping to active, engineered comprehension.
Yeah.
They are treating the patient's cognitive understanding of the drug as a vital sign, a metric that is just as critical to monitor and maintain as their blood pressure, their heart rate, or their respiratory function. Because if the comprehension fails, the medical intervention fails.
Exactly. So for you listening, the next time you are prescribed a new medication or you find yourself researching a terrifying new diagnosis, I want you to look closely at the screen in front of you. Pay attention to the architecture of the information. Ask yourself, is this platform just handing me a topographical map of raw data and leaving me to wander in the woods?
Right. Or are they providing a compass?
Are they lecturing me with static authority, or are they actively guiding my understanding through context and translation?
Because the way that information is built is directly and physically impacting your real-world health outcomes.
And I want to leave you with one final, slightly provocative thought to mull over as we wrap up. We've spent this entire time unpacking how human beings inherently struggle to process statistics, how we succumb to alert fatigue, and how we misinterpret raw data.
Yeah, all our built-in flaws.
Right. We have seen the monumental, highly engineered effort required by platforms like iMedix just to translate a single warning label. If human psychology makes it this difficult to safely absorb medical facts, at what point in the future does the curator of the medical information become just as important to your ultimate survival as the creator of the medication itself?
Yeah.
If the most chemically perfect, miraculous cure in the world ends up harming you simply because you misunderstood how to take it, then the unseen editor who translates that warning label is holding your life in their hands just as surely as the brilliant scientists who synthesized the molecule. Thank you for joining us on this incredibly unique journey behind the hidden curtain of medical media. We will catch you on the next deep dive.